going to start with talking about episcleritis and scleritis. That is the inflammation of the episclera and the sclera. And if you remember from the previous anatomy video, the sclera is the continuum of the cornea. It is a clear layer made up of collagen, and episclera is that thin layer anterior to it. Episcleritis is common and typically mild, transient, whereas scleritis is rarer because the collagen is very strong. It presents much more severely with a very painful and very red eye, whereas in episcleritis you tend to see more of a pink eye rather than a red eye. And the important thing is that vision is preserved in episcleritis, whereas in scleritis it may or may not be preserved. Episcleritis can be focal, which tends to be an autoimmune related disease, diffuse or nodular. It tends not to cause any problems, so treatment is rarely needed, but if severe, topical NSAIDs or steroids can be used. The way to differentiate between episcleritis and scleritis is to apply phenylephrine drops, and blanching will occur in episcleritis, but it will not occur in scleritis. Scleritis can be just a local scleritis, or it can have systemic associations such as rheumatoid arthritis. Bloods to consider doing include inflammatory markers, rheumatoid factor, antibody screen, and it is treated with topical or systemic steroids or immunosuppression. Necrotizing scleritis is a complication of scleritis with rheumatoid arthritis and is treated with topical and systemic immunosuppression. Other complications of scleritis include an avascular sclera, which appears white, and thinning and perforation of the sclera. We will now talk about the uvea. The uvea is the vascular part of the eye that includes the iris, ciliary body, and the choroid. And uveitis can be split into anterior, which is synonymous with iritis, intermediate, where the major site of inflammation is in the vitreous, or posterior uveitis. And commonly this is autoimmune. About 50% of anterior uveitis has infective causes. Eye drops are only useful for anterior uveitis because of the location being more anterior, whereas the other types of uveitis will need more systemic treatment, like steroids. So I'll focus on acute anterior uveitis, which is a cause of the red eye, and it is an emergency. It is the inflammation of the uvea and can be isolated, i.e. HLA negative with no underlying systemic disease, or it can be part of an eye or systemic disease. The anterior chamber is normally filled with crystal clear aqueous humour, but when the blood-eye barrier is broken down, i.e. in an autoimmune disease, then white cells and inflammatory cells infiltrate the anterior chamber. 75 to 90% of uveitis is anterior. 50% occurs in isolation and is idiopathic. It can affect any ages, but there is a bimodal peak at age 30 and age 60, and the prevalence between females and males are the same. Up to 50% of acute anterior uveitis is HLA-B27 positive. The peak age is at 30, and males are more affected than females, interestingly. In these patients, there is a strong family history and often have other autoimmune diseases. It is almost always unilateral or alternating, whereas HLA-B27 negative are usually bilateral. Recurrences are common and usually more frequent, and inflammation is more severe in HLA-B27 positive than idiopathic AAU. There are several rarer causes as well, but we won't focus on that in this video. So anterior uveitis presents as unilateral red eye normally, and a very deep pain and photophobia, and you often have blurring of vision as well. Under the slit lamp we can see some circumlimbal injections, and we can see keratic precipitates, especially inferiorly, and these are white dots, and the inflammatory cells are white blood cells, and that's known as non-granulomatous. We may also see inflammation of the anterior chamber, and that's particularly severe in HLA-B27 positive anterior uveitis. Posterior synechia may be present, and that is when the iris adheres to the ocular structures and it looks like it's stuck down to the lens behind it, and that is known as granulomatous anterior uveitis and requires steroids and mydriatic drops. It's important to dilate the pupils before examining to rule out posterior uveitis, which presents with white dots on the retina, and other things like retinitis and vasculitis. We want to do bloods like ANA, which will be present in any autoimmune pathologies, rheumatoid factors, serology for syphilis, toxoplasmosis, TB, etc. And we want to do HLA-B27, and if there's arthritis, we want to x-ray the joint. If there's suspected sarcoidosis within a chest x-ray. We manage this with frequent topical steroid like a dexamethasone or prednisolone acetate. We must exclude corneal ulcers before using this with fluorescein dye test, because if it's a viral cause of a corneal ulcer, then it will be exacerbated by steroid use. If severe, we can add a cycloplegic like an atropine or cyclopentolate to break up that synechiae. If unresponsive after 48 hours of using half-hourly steroid drops, then we really need expert advice and probably consider oral steroids. Thanks so much for listening. Check out the next Red Eye video on corneal pathologies.